Good afternoon. I'm Brett Perlman, and welcome to this week's edition of the Center for Houston's Future Leadership Webcast series. Through these conversations, we're building a framework on leaderships in times of crisis and looking at how leaders respond to complex and systemic challenges such as this pandemic. We've discussed the phases of a disaster and how the framework of adaptive leadership helps us move from response to unfolding emergency to mitigation and recovery, and then how to use the focus and energy of the crisis to respond to transition to new ways of working and behaving. Our first three speakers, Angela Blanchard, Judy Lee, and Senator Kirk Watson, helped us to examine the role of authority and what it means to exercise leadership. We've now turned our attention to public health experts to help us understand the transition from emergency to recovery and to understand what we must change in the adaptive phase. Last week's guest, Dr. Eric Bauerwinkel, shared how to transition to a phased reopening. And today, Dr. Stephen Linder will discuss how existing health disparities are influencing this crisis and what changes are needed for a more equitable and healthy community going forward. Through these conversations, we hope to consider the implications of the current situation and determine what actions we as a community must take to ensure the social, cultural, and economic well-being of the Houston region. So now I'd like to welcome our moderator, Russell Richard, and our guest, Dr. Stephen Linder. Russell and Dr. Linder, welcome.
Thank you, Brett. Good afternoon. I'd like to welcome everyone to today's webcast. I'm Russell Richard, Vice President of Leadership and Engagement with the Center for Houston's Future. The center was established in the year 2000. This year is our 20th anniversary. The center works to convene business, government, and community stakeholders in fact-based strategic planning and collaborations on issues of the greatest importance for the future of the Houston region. As I've done in previous webcasts, I'd like to acknowledge our leadership alumni on the webcast today. Thank you so much for your generous support of the center and our work. For those who'd like more information about the center and our leadership forum, please contact me or visit our website, futurehouston.org. Our next leadership forum is scheduled for September 24th of this year. The class is already half full, so please contact me soon for more information about the program and registration. Today is the fifth in a series of webcasts. Previously, we discussed the timing and stages of the crisis. Then we examined the concept of adaptive leadership and how it applies to this crisis. We took a look at the role of elected officials and how they should lead during the crisis. Last week, we examined UTHealth School of Public Health and the role it's played during this crisis. My guest this week is Dr. Stephen Linder. Dr. Linder is Director of UTHealth School of Public Health and Policy. Dr. Linder's work focuses on the community and health risk. He earned a PhD from the University of Ohio in political science. He's also taught at the University of UCLA and Tulane University before joining UTHealth. Dr. Linder also serves as a University of Texas System Distinguished Teaching Professor and a Fellow of the University of Texas. Dr. Linder, thank you so much for joining me today. It's great to have you on the program.
It's a pleasure to be here, Russell. Thanks so much.
Well, Dr. Linder, I think I speak for the Center for Houston's Future staff and others who are on the webcast that we really appreciate the great work that you're doing. So thank you. It's much appreciated.
Thank you.
Dr. Linder, what I'd like to do is the following. I'd like to frame our conversation this way. I'd like for you to explain UTHealth Institute health policy. And next, I'd like for you to discuss some of the conclusions from your research on the community-based healthcare needs and risk from your recent survey. Next, how has that research helped to create some of the maps that many of us have seen recently in the Houston Chronicle? And then next, I'd like for you to assess for us the reopening of the economy here in Houston. And lastly, how do all of these factors work together to inform us about the weaknesses of our healthcare system? And how do we address those weaknesses? So that is our framework for today. Let's get started. Let's dive in. My first question, Dr. Linder, is what role has UTHealth Institute of Health Policy played in COVID-19?
So our emphasis in the COVID crisis has been on providing data to aid decision makers and nonprofit organizations and local health authorities to be able to target their resources to instances where we believe communities are at higher risk, bearing a disproportionate burden of risk as a consequence of having those chronic conditions, those underlying medical conditions that have been shown to lead to higher rates of hospitalization across populations. And so we gathered the information that we had on chronic disease throughout Harris County, and we had the county divided into 38 areas, and we were able to then pinpoint those areas where the chronic diseases were most concentrated, so that, again, local officials could use that when they came around the issue of surge in hospital capacity and where to target information campaigns and where to locate testing sites. And we thought that a fact sheet for Houston was important, and we also compiled ones for Dallas, Austin, and San Antonio in the next round.
So Dr. Linder, can you explain the survey that you and your team conducted and some of the key conclusions, and how has those conclusions been reflected in this virus outbreak?
So the Healthy Houston survey is a random sample survey of 5,700 households in Harris County. And having a survey that large with that many respondents enables us to look at the sub-county level. And again, 38 areas were our focus, and we're able to then get at patterns that occur in terms of access to care and the prevalence of chronic disease and prevention behaviors, so that we can then program for community level activities that can prevent those diseases. And the emphasis in this survey has been on making the data publicly accessible. So we have on our website, healthofhouston.org, the complete data set for the 5,700 households. There's over 200 variables there of relevance to health considerations. And we make it available free to the general public and for organizations that have analytic capacity. We permit them to download the data for their own analysis. And that's really been one of our central missions. We didn't start out with some hypotheses about relationships we wanted to test, but rather we started with a list of priorities that were provided by over 80 organizations in the greater Houston area over what their data needs were, the kinds of considerations that they found most important in making their decisions. And so it really was an effort to make these data not only publicly available, but provide a foundation for evidence, a fact basis for actions that would be taken subsequently with respect to our healthcare.
Sure. Can you help us understand some of the chronic conditions identified by CDC that has caused an increased risk with COVID-19?
So initially, when CDC started reporting on the chronic diseases that appeared to be common among those who had been hospitalized, it was a fairly long list because their data were incomplete, and the reporting by states and localities weren't including a lot of the underlying conditions among those who had been hospitalized. And you can imagine in the heat of the moment that those kinds of data are not at the front of mind when you're dealing with a crisis with symptoms that you don't fully understand and don't have a prescribed treatment for. And so in those early days, there were 8 to 10 chronic conditions that were thought to increase the risk for hospitalization. and then more critically, moving from hospitalization to intensive care needs. And that appeared to be especially sensitive to the age of those who had been hospitalized. And literally there was a gradient that as patients were older, they were more likely to need intensive care. And those intensive care patients then were the main source of fatalities.
Sure. So we've seen quite a bit written recently by the Houston Chronicle and others about some of the communities that have been impacted. Can you help us understand a little better some of the characteristics of the communities that have been hospitalized by COVID-19, and have your projections played out the way you thought they would?
Well, let me start by talking about the revision that has taken place with the Centers for Disease Control knowledge of the underlying conditions. And as it turns out now, it appears that hypertension and obesity are critically important in predicting hospitalization of those who have COVID-19, and to a lesser extent, cardiovascular disease among those over 65. And it's those three factors that account for almost 90% of the hospitalizations. And we know, for example, that hypertension is concentrated in communities of color, and we have a higher rate of prevalence in African-American communities, for example, than we do in white and Hispanic communities. And it's almost 60% versus 40% in terms of the difference in prevalence. And what that means then is if COVID-19 spreads into a Black community, you're much more likely to have risk of hospitalization needs in that community because of the pre-existing condition, that the hypertension that seems to complicate the infection and to lead to hospitalization. So in effect, these communities are more vulnerable as a consequence of these underlying conditions, as a consequence of both hypertension and obesity, and again, to a lesser extent, cardiovascular disease. And they seem to be playing a role in generating greater disparity in terms of the fatalities that we're seeing. So the fatalities appear to be concentrated within the African-American community disproportionately from what we're seeing. And that, I believe, is largely a function of these underlying risk factors that are also disproportionate in the African-American community. And so then that leads us back to consider how it is we prevent the chronic diseases that create those vulnerabilities in communities of color.
Well, I appreciate you mentioning that, because many of us are watching the Houston Chronicle, reading the Houston Chronicle on a regular basis to keep up with some of these numbers. And just recently in the Houston Chronicle, it was noted that 40% of the people who have in fact died from COVID-19 were Black Americans. But what's also interesting is that only 20% of Harris County represents Black Americans, and I thought that disparity was quite interesting. Is there anything more that you could say about that disparity?
It is the case that populations of color and different ethnicities are distributed differently across the county. That is to say, there are concentrations within different communities. So to say that 20% of the county as a whole is African American is to really ignore the fact that there are communities that are majority African American located in certain parts of the county, and,
Sure.
and other communities that are a majority Hispanic, and other communities still that are majority white in the county. And so we have, because of the social patterning and the way settlement has occurred and historic reasons that had to do with earlier forms of segregation, and some having to do with the way the economy has developed and people settled around their jobs, we've got an uneven distribution of population across the county. Now, when you concentrate chronic disease within particular communities, as we see with hypertension in the African American community, you're likely then to find a concentration in terms of place. That is, certain parts of the county appear to be more at risk, more vulnerable to the ravages of COVID-19 as a consequence of these pre-existing conditions. And what we have then is a reinforcement of the pattern of disparity in the distribution of these conditions that are very sensitive to race and ethnicity.
Well, I appreciate you explaining that and kind of keeping with the Houston Chronicle, because a lot of us are getting our information from the Houston Chronicle. And again, here recently, the Houston Chronicle mentioned that 7 out of 10 zip codes with the highest rates are in fact majority Black and low income. But I also noted recently in the Houston Chronicle that Katy was among one of the highest areas with COVID-19. That surprised me. Did that surprise you? Did you anticipate that in your research and your projections?
Well, there's several things going on here. The first is that access to testing is not uniformly distributed across the county. There were limited testing sites that initially required that people be symptomatic. And not only that, that they also have a verification of their symptoms from a healthcare professional.
Sure.
So if you didn't have access to a healthcare professional or access to a car to get to the testing site, you were unlikely to be tested.
Sure.
So the initial rounds of testing were clearly focused on certain areas, and those are the areas where the cases first emerge, which is not surprising. The other factor in this is that population, again, in terms of density, is not uniformly distributed. And the density, even though the case numbers are higher in Katy, the density is far lower than it is, for example, on the east side of downtown or in the northeast of the city. So that you really, you're comparing apples and oranges when you're just looking at case counts. You want to look at the case counts relative to the population that's at risk. And so that's the adjustment that was done by Stephanie Lamb and others in the Houston Chronicle. They began to look at not just case counts, but case counts relative to population in an area, and they used zip codes as their geographic definition for the relevant population in that instance. As we get more testing, and the testing is then open to people who don't necessarily report symptoms or can't verify symptoms through a healthcare professional, and the testing is now free, we're going to see more cases spread out throughout the county, is my guess. And hopefully we're able to then, through contract tracing, get to those cases, trace down the contact, and through some quarantining, we'll be able to stop the creation of these hotspots where you've got serious infection occurring and multiplying through the population.
Sure. Well, clearly more testing needs to be done. I haven't really heard a lot about contact tracing. Are we doing any contact tracing right now?
We are. And in fact, the level of contact tracing has recently doubled in terms of not only the success in making the contacts, but the staff devoted to that. And the Harris County Health Department, I know, has augmented their staff and will continue to, because contact tracing is really critical to being able to manage the infection rate on an ongoing basis. Because COVID isn't going to disappear all of a sudden. It's going to be around for a while. And so we still have to think in terms of managing outbreaks when they occur, within the population. And contact tracing and testing is really the only way to do that until a vaccine is introduced.
Okay, well, I think the information that I've been following suggests that a vaccine is not going to happen anytime soon. Hopefully sooner than we hope. How do you expect the reopening of the city, the economy, to impact those communities most vulnerable, those communities that we just talked about?
When you think about how social distancing being very critical to the prevention of outbreaks, and it's actually the most protective factor in terms of avoiding infection in the first place.
Mm-hmm.
And the social distancing, it comes at a cost. And at one extreme, for example, you can social distance if you have the resources to leave the state and go somewhere in rural America where there's no current outbreaks. At the other extreme, you're really subject to not only the pressures from being unemployed and living paycheck to paycheck, but also having to put food on the table, having to manage your child care. And those kinds of stresses then threaten one's capacity to keep social distancing as opposed to seeking out employment. So in effect, at the lower end among most vulnerable communities, it's a good idea to begin, again, this complex trade-off about reopening the economy versus enhancing protection through continued social distancing. It's a good idea to begin worrying about the most vulnerable communities who are having difficulty now with food access, having difficulty with income, with their employment situation. And the key then is to not only make social distancing a widespread social practice, so that the vulnerable then, especially those who have chronic diseases, are better protected by their fellow residents, but also to ramp up the testing and contact tracing. And to some extent, the opening of the economy is really prompting much more attention to testing and contact tracing than we've had in the past. And it may be that's the action forcing device, that now that the economy is opening, resources are beginning to be funneled much more in a concentrated way into that contact tracing and testing duo. That's really critical for this to be successful.
Sure. Dr. Linder, are we reopening too soon?
From a purely health perspective, in terms of the risk of the infection, that may well be the case, but those decisions are social decisions made by our elected leadership, and we can't really second guess them because of the factors involved. And again, one aspect of vulnerability is the lack of income that people have, and they simply can't continue social distancing and maintain their health. That the social distancing requires some modicum of resources, and unless we can give them resources or give them opportunities to gain their own resources, it's going to make them more vulnerable rather than less.
Right. I understand. Well, there is a debate, as you know, about whether or not we are opening too soon. I'm just curious to know your opinion on that. Taking into account your survey and all the data that you have compiled, what has this crisis taught us about our healthcare system and public health?
There's several lessons that I think are important. One is the obvious one about preparedness, and the fact that we're catching up with testing and contact tracing means that the planning was inadequate for the scale of this challenge.
Sure.
And so preparedness needs to be one of the key lessons that comes out of this. There is a second one that I think is vitally important when you consider the the rate of hospitalizations. So about 20% of those infected with COVID-19 end up being hospitalized. And among those hospitalized, about 90% have an underlying condition. The obvious implication to me is we need to do something about the prevalence of those underlying conditions in the population. And if it's hypertension, we need to focus on providing people with the capability to control their hypertension. It's both expensive and stressful to manage chronic diseases. But to the extent that we've allowed that to be the natural way of life, that as you age, you accumulate these chronic diseases, I think is not the proper perspective. The perspective needs to focus on prevention in the same way we focus on preparedness. And it is about not only getting to younger children in school about prevention of those chronic diseases, but this is not a natural fact of life. It's something that can be prevented, and we need to focus on the communities with the highest prevalence of these conditions. Get them engaged and involved and forming organizations within that community so that they can together prevent that disease. It's not something you can do on your own in isolation. It's not something that a pill necessarily cures. It really is about having a collective movement within your neighborhood that can provide the social reinforcement you need for being more active, for eating healthily, for providing a set of opportunities to be healthier. And we need to see about those in a much more concentrated way, because this COVID has pointed up the serious risks and vulnerabilities that these chronic diseases entail, and how they're concentrated within communities of color and within low-income groups. It is something we need to remedy. It's not something we can live with.
Sure. Well, my next question kind of builds on that, and that is, how do we do that? I mean, what changes to our healthcare system do we need to make as a result of this pandemic?
Well, the healthcare system itself is really focused on dealing with people who already have disease. And if we think about health rather than health care, what we're trying to do is remove the barriers and increase the opportunities for people to be healthy, to live healthier lives. And we're on the prevention side of things. We're looking upstream before the disease strikes. And it seems to me an investment in our future is paying much more attention to the prevention side of things, so that we can engage communities not only in the actions that are constructive for better prevention, but also enable the community-based organizations to reinforce that. Because you have differences across communities in their capability to sustain this kind of social campaign.
Sure.
Some communities are well organized and have lots of social organizations, a lot of engagement. Other communities are fragmented and traumatized and have been impacted badly. We need to bring everyone up to speed so that prevention can be a way of life.
Well, I appreciate that information, Dr. Linder. This is very useful and very informative. I want to be sensitive to our time and maybe transition now into some of the questions that are coming in from the audience. So why don't we get into some of those questions now? And my first question for you is that hypertension has been listed as a risk factor. Does that still hold true if it's being controlled by medication?
So the CDC has gathered information from 14 states, and they're monitoring hospitalization in those 14 states. And from the CDC data, it's unclear whether or not the hypertension that they believe is present in disproportionate number of those hospitalized has been under control. There's been some research that has shown that ACE inhibitors, as a way of controlling hypertension, actually increase the vulnerability to more severe infections. I don't know that. A clinician would need to comment on on that factor, but the CDC hasn't provided us enough information to know whether being under control or the way it's controlled is a factor in the severity. So as it stands now, it's hypertension as a condition.
Sure, I understand that. Thank you. I appreciate that. Do the vulnerable communities of color suffer more because of the lack of access to healthcare? I know we talked a little bit about some of those preconditions tend to be more prevalent in those communities, but does a lack of access to healthcare, cause or exacerbate that problem?
It does, in the sense that managing a chronic disease, and again, we're looking at chronic disease as a key vulnerability to serious COVID infection. Managing chronic disease is not only expensive and stressful, but also requires regular interaction, a healthcare home where you can obtain the needed medications, you can be monitored, you can receive expert advice about your personal condition and so on, and that requires healthcare access. To the extent that there's not healthcare access, then what happens is not only do the chronic conditions worsen, but they tend to multiply. That is, you'll get hypertension then conflated with obesity and tied up with diabetes, and it becomes a metabolic disorder as well, because when you have a chronic disease that's unmanaged, it's likely to yield connections with other chronic diseases. And so you'll find people with 2 and 3 chronic diseases at the highest level of vulnerability to, again, severe COVID implications.
Right. Well, thank you. I appreciate that. I think we know that these conditions exist, and when we have a problem like COVID, they seem to be, take on new meaning, so to speak. Is there anything that UTHealth is doing to help educate those communities about some of these risks and what perhaps they can do to protect themselves?
Yes, we have collaborations both with the Harris County Health Department and with the City of Houston Health Department. And they have active programs in community education and interventions focusing on the control and prevention of chronic disease. And a number of our faculty are engaged as collaborators in those efforts, actually doing community-based research to find out which works best in terms of the set of ways that you can help people to improve the quality of their lives and overcome barriers to being healthy. And that work is going on.
Well, I know that we've looked at numbers in terms of infections, deaths, and recovery, and we know that there's a certain percentage of the population that's been deemed asymptomatic. How much more testing do you think needs to be done before you feel comfortable, you feel that the numbers that we actually have are accurate?
That's a hard question, and probably not one I'm able to answer very well. I mean, I have my impression about having tests that are universally accessible and that are distributed throughout the county so that there's kind of equal access to testing so that contact tracing can occur. And what that does, of course, is it assists employers who are able to then put control measures in place at the workplace because they're able to identify whether or not their employees are affected and then to do the contact tracing so that any flare-up and infections can be stopped so that the business doesn't have to close down again. So I see that as mutually reinforcing. The testing is, to some extent, it's in service to the communities, but it's also in service to the employers.
Mm-hmm. Mm-hmm. Well, again, the city is in the process, the state's in the process of reopening. Are there any markers or indicators once we reopen that might help us understand really soon if we're seeing more infections and need to take a different course or different action to correct or self-correct?
Well, Dr. Borling was on last week, actually headed a task force for UTHealth, and they devised a set of thresholds. The case level needs to be flat or declining over a 14-day period, for example.
Right.
Those, because the natural course of the disease is over a 14-day period, are fairly reliable about being able to damp down the infection rate. And again, if we can damp down the infection rate, we can keep people out of the hospital, because fewer people being infected have the chronic conditions that lead to hospitalization. And that's the ultimate objective, I think. I think the COVID-19 won't go away overnight as a disease that we need to face and address, because the virus itself isn't going to go away. And so we need to adapt to the changed way of thinking about how the disease is transferred, and how the coronavirus is actually spread through the population, and keep those measures in place for as long as we can, through social distancing and the personal hygiene measures that are important.
Mm-hmm. You know, Dr. Linder, it's probably impossible to live in the city of Houston and not notice our homeless population. Can you talk a little bit about the homeless population and perhaps people who interface with them and work with them, and how, you know, this COVID-19 has impacted the homeless as well as those who work with homeless people?
So the collaborative that focuses on the homeless has done a wonderful job in terms of reducing the overall level of homelessness over the last decade in Houston. And part of it is focused on actually giving people opportunities for single residence occupancy facilities and so on, and creating more shelter space and the like. It is the case that being out on the street doesn't give you the luxury of being able to socially distance. Being out on the street doesn't give you ready access to food. It doesn't give you access to the social support you need to deal with the other stressors that you face being out on the street. And so there's got to be a safety net in place, especially in times like this, where the disease is devastating, especially in the case of that constellation of chronic conditions, and people need hospitalization. The safety net has to find ways of giving those who are homeless an opportunity to not only find stable homes, but also support themselves with some sustenance, some access to healthy food, and again, the opportunities to social distance. Because social distancing doesn't come automatic, right? And again, it tends to be something that you need to be able to afford to do. And so we need to worry about that part of the population who can't afford to social distance.
Mm-hmm. Dr. Linder, has contact tracing been initiated in the 38 focus areas for COVID-19? And so what have we found out?
Yeah, I understand that it has. And the way contact tracing works is once you've tested positive, there's an effort to identify all of your recent contacts, that is the people that you've come into some interaction with. And then in turn, the team contacts them and requests that they self-quarantine for the 14-day period in order to stem the spread of the infection. And I know the state health department now has a website that they're encouraging people to go to for contact tracing if they've been diagnosed as positive. So it's not just people on the phone and people in neighborhoods on the ground were also using web-based contact tracing.
Dr. Linder, this whole, stay-at-home, shelter-in-place has given a lot of us cabin fever, and it's created, some mental pressure on many people. How do we work through the mental aspect of this COVID-19 for people who have been in place for 4 or 5 or 6 weeks now, who are really suffering?
Yes. So there's been an effort to actually bolster the availability of psychological counseling for people who are feeling the stress and feeling the pressure. And that's been accomplished through organizations like MHA of Greater Houston that has a variety of programs and are moving out into the community to attempt to deal with those issues more forthrightly. I know Menninger Clinic has also initiated some telemedicine opportunities where people don't have to go to the clinic itself, can be seen on an outpatient basis, and can get counseling directly. And I think that that's going to be happening more and more, and we'll see the opportunities for that increase. Again, the difficulty is access to care. And to the extent that you've already got access, you're more likely to be able to avail yourself of those opportunities for telemedicine. What we would probably need is more community-based programming. And I think we're going to see more of that soon.
Right, Dr. Linder, this reopen has created some uneasiness amongst a lot of people, but we realize that people do have to get back to work and to create income to support their livelihoods. And more than likely, when the dust settles, the economic damage to the city, the country, and the world will be probably much larger than we thought, what we imagined. What is the best way for us to go about prevention as we re-enter the economy, or reopen the city, the country?
I think to be effective, prevention has to be a social activity. And so it's actually the counter to social distancing as the way to prevent infection. Prevention requires a community that can reinforce the necessary changes in behavior or the necessary removal of barriers to being healthier. And so it really is that collective consciousness we've seen where people were asked to social distance, not necessarily for their own protection, but for the protection of the vulnerable that they knew, or of their elders, or of their parents and grandparents. And they weren't necessarily doing it for themselves, they were doing it for others. That other regardingness is really a vital kind of asset that we can take advantage of in the post-COVID era. And that other regardingness will enable us, again, to do the social investment that's necessary for prevention and healthfulness to be key features of everything we do.
When we watch the evening news, I think we see reports of different countries that are also dealing with COVID-19, and some of them seem to be doing better than others. Are there any countries out there that you have paid attention to, like Sweden or perhaps some other countries, that you really feel are doing it right and are a good model for the rest of the world, and the United States in particular, to follow?
It's hard to find a country that would provide the kind of diversity that we have in the US here, the kind of dispersion of population, but yet concentration in cities. I mean, the model for how one needs to deal with this is New Zealand. But they were able to endure a complete lockdown in their society for an extended period and are able to then recover from the economic consequences of that lockdown. For us, it'll be much more difficult because our government is a federal system of fragmented layers and by intention of the framers. And we don't have the level of top-down management that appears to be most effective in a crisis like this, but isn't something we're willing to tolerate within our political culture on a day-to-day basis. We don't want that kind of intrusiveness, that kind of directiveness on the part of our government. And so as a consequence, it's really been up to local communities to again, adopt what was necessary through that social distancing. When government provided us with the mandate, it was us who did it. And we did it with that sense of commitment to others within our community. And that's the real vital piece that we have that we can take advantage of in the future.
So, Dr. Linder, I think the last pandemic that we went through as a country was perhaps the flu pandemic in 1918, and I'm certain you've had an opportunity to research and understand that better. When you look at what happened in 1918 and what's happening today, do you see any parallels or anything that we learned back then that's being applied today that is actually helping us work through this crisis?
I think that the emphasis on collective action is more pointed now than it was in 1918. And part of the level of contagion was because we weren't coming together and focusing on ways of prevention. And there was a bit more laissez-faire operation that varied from city to city. And they continued business as usual, and the contagion ripped through their population. And so you had some cities that managed it well because they were willing to impose things like measures like social distancing, and other cities that were ravaged as a result. And the federal government played a substantially smaller role, even though it had been mobilized for wartime in World War I. It still played less of a role than currently. And so I think we're better off. The other feature of the 1918 pandemic is that it unleashed a decade of very creative activity. And so culturally, there were some effects that were positive for the society as a whole that came out of the really dire straits that infection created.
Sure. Thank you. Well, Dr. Linder, we're out of time, but not out of questions. But thank you so much for being so generous with your time today. We really appreciate you being here and sharing your knowledge and insight. I think it's helped us all. We're all a bit more educated having listened to your presentation and answered our questions. I want to also thank you.
And let me thank your audience as well for their attentiveness and asking those hard questions.
Sure. Well, thank you very much. I want to also thank our viewing audience for tuning in today. Please be on the lookout for more information about our next leadership webcast. I'm Russell Richard. Good day. Be safe. Stay well.